talking today on the management of osteoarthritis of the knee in the active patient, and this is a fairly complex area where we don't really have all the answers, if any of the answers, but this talk is it's based mainly on the JS article, but on a few other things we'll get into. But hopefully this will give you a little bit of a pathway to use when you get to the patient who has painful osteoarthritis of the knee. They're usually younger patients and more active. So the article we used was this article from 2010, and luckily, or not so luckily, the American Academy of Orthopedic Surgeons have just released their evidence-based guidelines, their second edition, for the treatment of osteoarthritis of the knee. This is a 1,300-page document, and if you've got a free 20 or 30 hours, I'd suggest you use them for something more interesting, and and go and read the JS article, which is a summary of it, which just gives you 15 recommendations. Doesn't go into much detail, but does give you the recommendations, and they base their recommendations on these criteria: strong, where there is either a positive or negative outcome from the management, and where there's good, strong evidence. Moderate, where you've got either a positive result from a treatment regime or harm, and the evidence is reasonable but not strong. Consensus, where there's no good evidence and it's just what people are currently doing for their management. Inconclusive, where we don't know the answer and some people do the management, some people don't. And this year for this, so they did their previous guidelines in 2008, and they've changed a few of their guidelines because they're now looking at minimum clinically important improvement. So no longer are they looking to see what the evidence says in regards to whether something is significantly or better, or whether it has significant outcome. They also now look at whether not only does it have to have a significant result mathematically, they also need to be able to show that it has a clinical importance or there's a clinical improvement in the patient. So we'll look at that. Introduction, so osteoarthritis is basically a breakdown in the repair and tissues in the synovial joint. We know there are multiple risk factors: trauma, overuse, increasing BMI. So we use that now, Mr. Hoare, not fat. You get in trouble if you say that. Age, so increasing age, females, and genetic predisposition. It's a very common thing in the osteoarthritis. Incidence of 240 per 100,000 in the US, and there's about 10 million people walking around the US today who have symptomatic osteoarthritis in the knee. In Australia, last year, there was over 350,000 total knees from when the registry, on the registry, and over 97% of those are for OA, and that's a 90% increase compared to 10 years ago. In regards to management of knee OA, obviously our goals are to reduce pain and to have the patient functioning. There's a risk reduction, which is essential in our management, and it'd be great to say that for all young people, the panacea is a total knee replacement, but unfortunately it has its problems. So we know that there are earlier failure rates in a younger person who's more active. We know that at 4 years after having a total knee replacement, if you're under the age of 55, you have 5 times greater risk of requiring a revision than someone who's 75. We know that then you go on to likely need multiple future operations, and we know that a total knee replacement, to try and reduce this risk of needing earlier revisions, that there is lifestyle modifications. And in the younger active person, this may not be what they consider to be what they want for their life. This was the Knee Society back in 1999. Some of the knee surgeons there were asked what they recommend their total knee replacement patients, what they recommend them to do, or what they tell them they can't do. And if you have a look at some of these things they recommend: low impact aerobics, croquet, shuffleboard, They may as well all move over to Florida and retire. So these poor people are being sent off, young, fit people who are in their 40s, 50s, being set off to a life of a person in their 80s. And so this is one of the reasons why total knee replacements, or do we need to change our thoughts on what activities people can be allowed to do. Looking at our registry, don't know if this is projected all that well, but primary total knee joint replacements, age under 55, the green one down here has been stable at around about 6% for the past 10 years. You can see that between 55 to 64 that the rate is increasing. And if you look at the revision rates, you can see that the male revision rate increases, and you can see it starting to diverge away from femoral. And that's likely due to the increased activity that men have. The revision rate of a primary total knee by age, and this is where we've said that the younger active people do worse. And you can see here it continues to diverge. The younger you are, whether it be less than 55 or 55, 64, you continue to require a revision far earlier than those who are older. Yeah, and so up to 7 years, you're 7 times the risk of needing a revision. So this is the pathway or the algorithm that's suggested by the American Association of Orthopedic Surgeons, and this is the way they look at managing the younger person, the more active person who has painful symptomatic osteoarthritis. And so I thought what I'd do is I'd go through and have a look, and I'd just see what evidence there was for each of these and whether we should be following this algorithm or if there's anything else that we should do. So the first thing on it is exercise, physical therapy exercise. It's the first thing they suggest we do, and I think most of us in our practice will do that. And there's good reason for that. So the new guidelines recommend, and they strongly recommend this, there's good evidence, there's multiple articles to show that self-managed programs, which include strengthening, aerobic exercise, low impact stuff with neuromuscular stuff, which includes proprioceptive retraining, is significantly improves both pain and function for these people. And the evidence shows that it's out to 1 year or more. We just don't have more data than that. So there's multiple studies. Muscle strengthening is sometimes thought to be more beneficial for pain, aerobic exercise more for functional outcomes. It is shown that multimodal approach is better than any one specific exercise, that there's no difference in the type of strength exercise you use. That aquatic therapy, so hydrotherapy, is of benefit, but probably earlier on in the process. As I said, the most benefit you get is from a multimodal approach. So a multimodal approach, tailor it specifically to the patient, and these results, the research shows, last for a year or more. It's just that that's what the research, strong research, is out to a year. But there's significant improvement in strength, in pain relief, and in function. So they get a gold star for the home exercise and for physical therapy. It should be our first treatment or management program in any patient with knee arthritis, especially in the younger active person. Other manual techniques, that they have any benefit, and that includes manual therapy such as massage, muscle stimulators. So there's no good evidence to show that they have any benefit. There's some evidence to show that ultrasound can give a very small improvement. Cochrane did a review on that, and it's only about a 2% improvement, so probably not going to be of any use to you. Acupuncture, the American Association suggests that acupuncture not be used. Not that it causes any harm, but there's strong evidence to show that there is no benefit at all. We come on to weight loss. So weight loss is recommended for those who weigh more than, with a BMI more than 25, so who are in the overweight category or more. And loss of weight is a moderate recommendation, so there's lots of literature out there, just not great literature. Shows improvement in both function and pain. It works best if you do both a diet and exercise regime. It's found that if you just do diet, the functional improvements aren't as good as those who also have diet and exercise. And we also know that loss of weight or increased BMI is an independent risk factor for once they go on and require it in their replacement. In both the perioperative period and post-operative period, there's increased complications if the person does have a higher BMI. In regards to bracing and orthoses, where do they come in here? Do they have a role? So for a person who has a single compartment OA with a fairly stable knee with less than 10 degrees valgus varus, then there may be a role for the knee orthoses. The evidence there is not strong, but for pain relief it may improve it and give them some functional stability, but there's not strong evidence for that. In regards to lateral wedge orthoses, there's been multiple articles on this, and there's another one out this year, a systematic review, which shows that it has no benefit. So the lateral wedge in the shoe has no real benefit. This was the thought of the American Association that the knee splint is inconclusive, but there's moderate recommendation for the wedge insoles not to use them. Cochrane did a review on this as well, and they thought that there may be some benefit in walking distance for the knee brace, but once again, there was not enough evidence to be able to strongly say that there was much improvement. So this would be used as an adjunct to your management for exercise. In regards to medications, so first-line management for knee OA in the younger person or the active person is non-steroidal anti-inflammatories, not aspirin. And there is strong evidence, with multiple evidence in the literature, to show that non-steroidal anti-inflammatories have good benefit. Okay, doesn't really matter which one you use, although you need to relate it to your patient. Anyone who's had GOT bleeds in the past, you need to be careful. We know there's a 2 to 4% risk of having a bleed from long-term use, and that risk is high with COX-2 inhibitors. You need to be careful with those who are on anticoagulant therapy and who have cardiac or renal failure. But we know that up to greater than a year, non-steroidal anti-inflammatories reduce pain and more so than function, but help with both. Where do opioids fit in? Well, the American Association of Orthopedic Surgeons have said that they can't really say. The evidence is not strong enough for the use of opioids. Cochrane did a review in 2010, and they found that, sorry, it should be 6%. There was a 4% improvement in pain and a 6% improvement in function, sorry, 3% improvement in function, but there was significant increase in side effects, including constipation, nausea, and drowsiness, and so they did not recommend the use of opioids for people who had painful knee arthritis. So, where do we stand here? Physical therapy is good, NSAIDs are good. So that should be our first line management for these people. Next, we go into viscosupplementation and corticosteroid injections. What's their role now? So the guidelines from the American Association in 2008 recommended viscosupplementation. That has now changed, so they no longer recommend it. And that is, in fact, they recommend strongly against the use of hyaluronic acid. And their thoughts are that the evidence now is strong enough to say that the benefits are too small to be of any clinical importance to the patient. So some of the studies show there to be minor benefit, but the American associations feel that that benefit is not of any clinical significance. Some of the research talks about the viscoelastic properties and anti-inflammatory effects may be of some benefit. Cochrane did a review in 2009, and they said there may be some short-term pain benefits which only last for about a month or so. So it's thought that if you do use it, the benefits aren't very large and last a very short period of time. So that's why the Registrar Association have now said not to use it. In regards to corticosteroid injections, the recommendation is that there's not enough evidence to say whether this is of benefit or not. There are some lower quality studies out there, and they do show improvement in pain, not in function, but in pain. And so, unfortunately, those studies have muddied the water a bit because a lot of them do it with hyaluronic acid, and there are some injections which have affected chondrocytes, such as lidocaine. Cochrane also did a review here in about 2010, and they felt that there was some benefit, but that it lasted a very short period of time, 2 to 3 weeks. So once again, whether it's of any benefit to the patient to reduce their risk of going on to needing a knee replacement or to manage their activity levels, it doesn't look likely to be of much benefit. Another one, everyone's favourite, the platelet-rich plasma or the growth factors. The American Association have also said that it's inconclusive. There's not enough evidence to show of its benefit in pain reduction, and right now it's up to the discretion of the user, but it's currently there's not enough evidence to recommend using platelet-rich plasma. So, physical therapy is good, NSAIDs are good, viscosupplementation is probably not of any benefit, corticosteroids possibly, but if they do work, it's only a very short period of time. So where do we go from there? If we've exhausted exercise, we've exhausted our NSAIDs, what happens now? So the clinical practice guidelines strongly recommend against arthroscopy for chondroplasty and lavage, and the literature now shows there is no benefit when you compare it to physical therapy and medical management, but you do have increased risk of harm from anesthesia, infection, venous thromboembolism. When talking about meniscal debridement, however, so if a person has an acute onset of meniscal tear symptoms in a osteoarthritic knee, then there may be some benefit in going in and doing a debridement. This is controversial. So some literature found that people improve at 50% after a debridement of the meniscus, but then 15% still went on to have a requiring a knee replacement at 1 year, and there was no benefit after 2 years. The JS article talks about benefit probably being best in a younger person who has the single compartment OA, where it's mild OA and the onset of the meniscal type symptoms is recent, and it's more of a localized type pain rather than diffuse osteoarthritic pain. So there may be some benefit in meniscal debridement, but there is no benefit in going in and doing a lavage and a chondroplasty. These people do not improve from that. What about HTOs? So the clinical guidelines say that there is limited recommendation for a HTO, and the quality of studies are low quality, but there is a significant improvement in pain, but there's very minimal functional improvement. Some of these studies have shown that survivorship can be up to, at 10 years, can be up to 98% after a HTO. So these people aren't needing a knee replacement within 10 years. These studies aren't great, but that's some of the range. Some of them say up to 20 years that only 70% but once again, this is not a small operation and not without its risks. It's the main, just for some retrospects, the main reason we do it is for to delay the need of the knee replacement, and it's obviously redirecting the mechanical axis onto an area of the knee which is more preserved. It's contraindicated in previous mastectomies or significant degenerative disease of other compartments, including the patella, and you need to counsel your patients very wisely because aesthetically they can end up with a valgus knee, and so they need to know that before you do this. The patient should have a good range of motion before thinking of doing this. The one benefit is that these people can go on back hopefully to close to their previous activity levels, and so in the younger person, this is why we look at this being a good management regime, is because unlike the knee replacement, these people tend to get back to closer towards their activity levels that they'd like to be at. Risk of failure here, the older you are, the longer time since having the HTO, overcorrection, and once again, obesity is an issue. So, osteotomy gets a half star. It has its benefits, but you really need to choose your patients very wisely. What happens if the patients are appropriate for that? Unicomps, is there any benefit in the unicomp? So, previously we used to think you do unicomps in the older people, lower BMI, intact ligaments who have only unicompartmental OA, usually medial compartment OA, and who don't have a major contraction. There is a trend now to use it more in the younger patients, and the reason being is, so there's multiple reasons, but some of the literature out there shows that these 90% of people after a unicomp return to athletic activities which are preoperatively compared to only 60%. The literature here is a little bit muddied, whether that's because we counsel our total knees and tell them not to go back to any high level activity because they'll fail, and whether then they're too scared to go back. That might be one thing. There is some literature that talks about talking to patients who say that if they're happy to go back after a unicomp because they feel if it fails, then they can go into a total knee. So we've got a backup. The other thing is that these patients, to be suitable for unicomp, usually have better function and less anatomical derangement than those who go into a total knee. So they're probably already better functionally, and so return to functional activity better. Some of the studies show that they have excellent results with a survival of 92% of 11 years. That's not what we find here in our registry, which we'll have a look at in a second. There was 39,000 unicomps done in Australia last year, but the number is actually decreasing, whereas the number of total is increasing. Just having a quick look here. So the age groups, the major age group we do it is actually the 55 to 64-year-old. The less than 55s is about 12% that we do it on. When you look at the percentage revision of unicomps, you can see that it steadily increases, and at about 12 years, it's about an 18% risk of revision, compared to the total knee, which is flattening out, and it's far lower. It's about 6%, less than half. In fact, if you look at the male versus female, the males actually go from being a linear curve to about 10 years where it starts to pick upwards. So men do worse, especially, and it looks like they will continue to do worse as time goes. Looking at the failure rate with age, and as you can see, as with total knees, in a unicomp, they do worse, and it looks like worse early, and then continue to do worse. And that's comparing that with the primary total knee, where you can have a look at 12 years is greater than 25% revision rate in a person younger than 55 if they have a unicomp. So, unicomps, if you choose the right person, can have some benefit and can stave off a total knee, but is also not the panacea, half gold star. So total knee, we spoke about that before. It is of benefit, but you need to, the patient needs to be well counselled that their activity levels are likely to be considerably decreased, that there is the risk of going on for having revision surgery in the future. So, in summary, looking at this algorithm, I think we all need to get our patients treated early with physical therapy, home exercise program, weight reduction. We need to start them, if possible, on non-steroidals. There's unlikely to be a place now for viscosupplementation, corticosteroid injections. If it does have any benefits, likely to be short-term. There's no place for arthroscopy for lavage or chondroplasty, but there may be a place in a person who has a new symptomatic municipal tear on the background of osteoarthritis. High tibial osteotomies are a benefit in the younger patient who fit the criteria and can hold off the requirements for a total knee replacement for many years. Unicompartmental surgery is a benefit for those also who fit the criteria, but the patients need to be told that their failure rate is far more higher than a total knee, and that they're likely to need to go on to a total knee replacement. Thank you.